Coffee with Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape. Welcome back to another episode of Coffee with Coker. I appreciate everybody listening. And today we're going to jump into a discussion on actually something we're following up on. We've talked about it before at varying levels. And today we're going to actually jump into a specific component of the final rule for the 2022 Medicare physician fee schedule. Specifically, we wanted to talk about changes to the split and or shared billing between APPs, advanced practice providers, and physicians. Some changes that are happening there that are very relevant to billing correctly and billing requirements for whether it's an independent practice or if it's hospital owned or anything in between. So we want to get into that here, and joining us today, Alex Kirkland, who's been on before, and he's joining us, and Chris Marrs as well. Both team members for us that work in our physician compensation practice, and they are definitely the experts to refer to when it comes to all things compensation. Before we jump into the conversation, I like to just cover a quick housekeeping item. We always, again, thank you for listening. We want to encourage you guys, if you like this type of information in this podcast, you can listen to all of our podcasts. You can find those at coffeewithcoker.com. You can also go follow us on all the social media where we post regularly on varying topics and developments within the healthcare marketplace, as well as things going on coming from us as far as different thought leadership pieces. And you can find all of our thought leadership and insights on our website, cokergroup.com. So again, we thank you guys for being interested in this type of material, and certainly I want to encourage you guys to go and check out the rest of the information we put out. With that, I want to jump into the conversation. Again, we're talking about the changes to the split or shared billing in the final rule. And we like I said before, we talked about this in other episodes as far as the final rule and some of the different changes in billing and the other things related to that. We wanted to follow up and dive into some of the more specific pieces of that rule, and that's what we're doing today. This is a pretty big one as far as billing between APPs and physicians. First, I should say we're talking about this topic today, but Alex and Chris actually have written an article covering this topic in a little bit more detail certainly than we could probably get into here with a quick podcast. So we'll make sure that's linked over in the notes for the show. But please feel free to go and review that. And then obviously there's a lot here, even more than we could cover in an article. And so if you have specific questions or need to look at things at a deeper level, more details, or kind of understand how it may really affect your specific organizations, I really encourage everyone to reach out to either Alex or Chris or both, or reach out to us, and we'll put you in contact, because they are absolutely the best people to answer your questions and provide any additional insight you may want. So you can find all that contact info and the information on Alex and Chris at our website. Again, that's cokergroup.com. So with that, Alex, maybe if you want to start and kick us off here, I want to take a quote here from the article that you guys wrote right at the beginning. And really, I just want to define, or I guess this in the rule is defined what split shared billing is. And it's defined as an E&M visit in a facility setting that is performed in part by a physician and an MPP who are in the same group. So pretty straightforward. I think most groups out there are aware of kind of the current or previous requirements for billing for those split visits. But talk about what that means maybe at a high level before we get into the specific changes.
Well, I think the fundamental concept to think about is how CMS, who is updating the prospective rule that we're going to be talking about, how they're trying to better align reimbursement with services performed. And right now, that these services, these split shared visits, are being billed under the physician name. But the physician may be in a situation where they're providing most of that service time with the patient, or what a number of organizations and physicians will run into is that maybe they use their APPs in the hospital setting to round on patients. And so the physician may duck their head in for a quick minute to consult with the patient, but the APP, the advanced practice provider, has spent the bulk of the time with the patient. Right now, the rule allows for that billing to take place under the physician name. What CMS is doing is that they are saying now in 2024, and we'll get into the timing changes of when this all takes effect. In 2024, what we're going to do is we're going to pay either 100% of that service if the physician spent the bulk of the time with the patient, and they're defining that as over 50% is the substantive portion of time, or if it's determined that an advanced practice provider has spent over 50% of the time with the patient, then they're going to reimburse it at 85% of the service. And so CMS is trying to drive their reimbursement to be more consistent with the provider that is rendering that service or fulfilling that patient care. The implication for this is that historically, because the services are billed under the physician name, they've gotten all of that work RVU credit. And so now what is going to happen if that work RVU credit is being redirected to the advanced practice provider because they're fulfilling the substantial 50% of the services?
Interesting. So a couple things there. I guess at a high level, one could say, okay, this is a pretty, there's nuance to it. Obviously, there's relatively straightforward change, but in terms of applying these changes at the ground level, if you will, meaning groups actually doing this, it's not such a minor change. And then when you talk about the impact, the implications you just went through, as far as the impact of a production credit, which then translates or correlates back with compensation and how that's distributed, certainly could have even more significant effects. So we want to talk about some of those effects, but you referenced there in your previous comments about the timing. What changes have been made there?
Well, Chris, walk us through what the plan was and how CMS has kind of reacted to this in their proposed rule. That we're still waiting on the final rule for 2023 to drop, expected to come out November 1st. And so that'll give us some more information, but they did give us some updates as far as what they had originally stated versus what the current thinking and plan is.
Yes. So essentially, this year, 2022, was supposed to essentially be the transition year. So obviously, when you're changing work RVU and billing attribution, that's going to impact your EMR system. You don't have to track time spent on all of these visits. So just operationally, it's a pretty significant change. And I think because of that feedback in the 2023 proposed rule that came out in, was it July? The timing has shifted from where, now 2023 is also part of a transition year. So health systems practices have another year to kind of figure out how to operationalize this and track all of the data that they need to track. And 2024 is when this will completely go live, and all attribution and billing will be based on whether the visit was greater than 50% of the time.
Is what's been delayed, is that just this ruling on split shared billing, or is that for everything, all the changes?
Just this specific component.
Gotcha. And you mentioned time, the operational changes that will be required, but one is the time, I guess, tracking. Has there been any, discussion around what that needs to look like? Are they having to document that, and verify, hey, based on the number of minutes allocated here, this was 50% or this was 80%, or is it kind of more like honor system?
The majority of time is defined as greater than 50% of the time spent on the visit. With regards to tracking, we've seen some hospitals try and do this in different ways. Some of them are looking at doing a simple checkbox type thing where whoever spends greater than 50% of the time gets a checkbox and in the EMR system, and that's how it's recorded. we've also seen more detailed tracking options where, one would try and track the minutes by provider spent on a visit. This obviously is quite a bit more burdensome. And, paperwork in healthcare is already fairly burdensome as it is. But tracking every provider's number of minutes does have some other benefits, partially because, while it's not going to affect billing, the practice or hospital can essentially go in and say, here's who spent the majority of the time, but who is spending what portion of time on average. So this will impact, potentially some of the compensation changes that may come as a result of this. But, if a hospital finds that on average, a physician spends 25% of the time with a patient per visit where the visit is billed for the APP, that can potentially be used to get a better look at real work RVU attribution between physicians and APPs.
Gotcha. That makes sense.
And what's interesting is, kind of tracking how CMS has responded to their rulemaking in future periods. And so it's a really complicated way of saying that previously CMS came out and said, effective 2023, this is going into practice. And so that's how reimbursement's going to be tracked. It's how work RVUs need to be attributed, all of those types of considerations. Now they've come out with the proposed rule for 2023 that is saying they're going to delay the implementation of this another year and allow for 2023 to now be the transition year, as Chris was stating, so that organizations can kind of iron out and have a better sense of what is the materiality of these types of practices. They're ultimately going to have to defend audit practices, coding audit practices, what do the notes say, all of those types of things. And so they got to be copacetic with that. But CMS has historically recognized concern on progressive changes, and they have historically delayed some of those changes. And we saw that take place in this new proposed rule. They've delayed the implementation of this. Doesn't mean that they are forgoing this implementation. Like we've seen in previous rulemaking, it will eventually get implemented. It's just that it got delayed to give providers more time to get acclimated to these changes.
Yeah.
What will be very interesting to see is if there are further concessions CMS makes when they drop their final rule on November 1st. And what they typically will do is they will there's a comment period that people can go out to and share thoughts. And so what CMS will do in their final rule is they'll list the comment that they've received and what their reaction to that comment is, why they've decided to move forward, why they've decided to take that into account, whatever the case may be. I do expect that they will implement this in 2024 as they have now said they would in the proposed rule. But as we've seen in prior rulemaking processes, there's been some concessions that, we'll give a little bit more time to get people acclimated. And so I think the takeaway right now is that 2023, that is the transition year. Reimbursement is not going to change in 23, but it's the time period that people should be getting acclimated to these changes. And in 2024, it's expected to go into practice. Some variation of that I do expect to take place, but it will be interesting again to see what kind of concessions they may make, as the final rule comes out, how they'll comment on or react to different comments they've received.
Sure. Yeah. Well, that context certainly helps. And I have to think this is not uncommon for, something to happen at the federal government level where, the general concepts are there and at least understood. Maybe, whether they're supported or not, may vary, but at least understood again, in theory or a conceptual level, but at an application level, wasn't fully considered yet. So that time is needed to make sure that the changes are not only reasonable, but the expectations are also reasonable.
And what Chris was saying, like what's going to hit the fan on this is all what happens with the work RVU attribution. And it's like that drives the majority of physician compensation.
Right.
While this is for a hospital or facility setting, And we typically see time-based compensation models for hospital-based physicians. You think about specialists that round in the hospitals that are very much on work RVU models. It is going to have an impact on them. And so what are some mitigation strategies that organizations can deploy? That should be very much part of their planning process now that they have the transition period of 2023. How are they going to do this? And I think a big part of that is just change management. How do you educate the physicians on how this is coming into play? Because I mean, the physicians have got to be getting legislation fatigue for all these changes that have come out in recent years with the new work RVU values, with shared split visit, new changes that take place. And so there's a lot of communication that's likely needed, and then some mitigation strategies that need to be thought through and considered as well.
Do you anticipate, obviously this is a little bit like asking you to look into your crystal ball here down the road, but if physicians end up as a result of these changes, essentially making less per RVU or somehow changes that ratio, somehow impacts that ratio, whether it's less per RVU or something else, is that going to change the benchmarks then that come out in subsequent years?
It's a great question. And if you think about benchmark data, survey data, what is survey data? And so it is a reaction of what has happened in the market and how organizations have reported compensation and production. And so do I expect to see survey data evolve over time to reflect this dynamic? Yes, absolutely. Is it going to be day one? No, because survey data is reactive in nature and it lags a year. And so it's going to take some amount of time before we see this impact show up in the survey data. And will we see an increase in work RVU because the physicians are no longer to be credited as mini work RVUs? Possibly. That's a crystal ball forecast. That's going to be considered alongside, well, are they getting a new stipend to oversee advanced practitioners? So all of that will come together. But I think the one thing that we know is that the surveys will not pick up on this nuance the moment it gets implemented. It's going to take some amount of time before we see production benchmarks and compensation benchmarks reflect what these changes are telling us. And we're seeing that on the new work RVU values that got rolled out. The surveys are very much in a mix where they're dependent upon organizations reporting work RVUs. Well, are they reporting old work RVUs? Are they reporting new work RVUs? If an organization switched during the middle of a year, they have their fiscal year that's June 30, what work RVUs are they reporting? And so it just takes a little bit of time for survey data to catch up to the reactive nature that it gets reported on.
Yeah. And I'm sure there's both objective and subjective elements to interpreting and applying survey data because, like you said, if it happens over time, you kind of have to adjust for it as it evolves. But then also take into consideration any changes that do come, are going to have to kind of balance out over time, and you have to make certain decisions and apply judgment where necessary.
That's exactly right. And so it's really, there's a lot of moving pieces that make it a complex valuation. And so it's not just going to a survey table and saying, oh, here's the 60th percentile rate per work RVU or 75th percentile rate or whatever it is to determine this is fair market value. It is, well, what are the facts and circumstances that you're considering? What is happening within the market? What is happening with coding profiles, and a host of considerations that have to be considered to determine that fair market value ultimately will end up being.
Right. And, I think the time piece, the getting a better understanding of that time per dollar or time per reimbursement or time per unit, whatever it is going to be something that has to be figured out and kind of leveled out over time as well. Because if organizations aren't tracking that right now to the level of detail, Chris, that you were talking about, or if they are, but at a high level, then they may have to make not only the operational changes, but then, the changes that impact the provider's compensation and then incorporate that into their compensation model, which in turn, those models may need to be updated and then valued.
And that's our guidance to clients, is that use this period now in 2023 to help understand what is your baseline, how is this going to move things? Because what you don't want to find yourself in the position of is that on January 1st, 2024, without doing anything, now you find yourself in a position where some of your highly compensated, highly productive physician leaders of your medical group see an abrupt change. And that we don't want to see that take place without the awareness of it. How can you plan for it? What can you do so that it's not create, dissidence that it does not necessarily have to create?
Right. That makes sense. Talking about the impact on compensation and potential changes there, Chris, in your article, y'all go through a number of key effects that we anticipate these changes, depending on what the final rule ultimately looks like. But some of the likely changes that are effects that can be expected from those changes. Talk a little bit about how you think the impact on comp is, maybe get into a little bit more specific what you think the impact is going to be there.
Yeah, it looks like it's going to change in a few ways. You've got lower physician work RVUs, which typically means a little bit lower compensation for physicians. You've got higher APP work RVUs. And so as APP compensation models potentially shift to be more production-based, you have potentially higher APP compensation. You also have lower collections, because the work RVUs attributed to APPs, those visits are going to be reimbursed at 85% rather than 100%. This also may change APP supervision, where that becomes a more important and a more common part of physician compensation. So we could really see a number of effects, ranging from higher APP compensation to potentially lower physician supervision compensation, with some of the decrease in physician compensation potentially being made up by APP supervision being a more important part of the services that physicians provide.
That's interesting. So I know there are a number of different approaches in terms of how APP compensation is based. It can be heavily tied to the physician. It may be in some cases it's very independent from a physician. And so I have to think that may be something. I don't know. There may be some things that change there. Do you guys anticipate, or maybe again, this is kind of asking you to look in your crystal ball, but any thoughts around the reasoning behind these changes? And what I mean is this something that could potentially change actual provider behavior? Meaning if a physician traditionally has kind of done his or her thing and in coordination with their APP or an APP, if they were tracking detailed time, you may find they were actually spending 30% or less than 50%. Whereas now, if it impacts their compensation obviously in a negative manner, then are they going to be more likely to make sure they're spending more time with that patient themselves personally and to get over the 50%, or no, we'll work it out on the back end when it comes to compensation and comp relative to production, and not change our behavior. The approach stays the same. We'll just figure out how the money flows after.
At a macro level, why are they doing this? Well, healthcare costs are 19% of GDP and keep going up, right? They're trying to bend the cost curve. And this is an exercise where CMS is saying, hey, the provider that's providing the bulk of the services, that's what we're going to reimburse them. And so you think about it from CMS's perspective, they may feel like they've been overpaying for these services for some amount of time. And so they're trying to curb healthcare costs, the amount of that is rolling out in this regard. So I think that's what's driving the change for this. It makes sense why they would do that. As far as how this is going to impact physician behavior, this is speculation. And so let me be clear. But what I would suspect that we could see is the rise of the ISTs, meaning you've got a hospital cardiologist. You've got all of the different ISTs that could come into play, because the traditional specialist that's serving these patients, they may say, well, if I'm not going to get production credit or something that drives compensation. Well, why would I go do this? I can go spend more time in my clinic and do these and be scheduled for additional time for procedures in the OR, whatever it is, and leave this to someone else to focus on. And so what we may see is some additional ISTs that are brought into play that are focused on some of these hospital-based services.
Yeah, that's interesting. You guys talk about in the article who these potential changes really incentivize, and I wonder about the impact on efficiencies and the changes or what APP utilization looks like if the physicians are more incentivized to perform work that really is more appropriate for an APP. And it sounds like that's what you're kind of getting at is, if those incentives aren't aligned and it doesn't make sense for a physician, particularly a specialist, to do something when an APP can cover it and they can be off doing something else, what does that mean all the way down to the impact on the patient? I mean, if the physician is, spending more and more time doing stuff that traditionally APPs have done, then that's less time for, maybe blocks of time in the OR or clinic follow-up time or whatever it may be, like you just referenced. Is that what you're getting at?
Yeah. I mean, I think behavior will change as a result of this. I mean, there's a lot of pieces at play. And so as stakeholders, whether that's physicians, APPs, hospital administrators, medical group executives, CMS, whomever, I mean, they're going to react to how behaviors change and how data moves. I think the number one takeaway is that you can't put your head in the sand about this because it's something that's coming. And so you need to be prepared for it so that you don't wake up and find yourself with a physician that's abruptly impacted by these changes. Mm-hmm. And so that means that you've got to have a plan. And my favorite business quote is by Peter Drucker, who said, the executive without a plan is just a prisoner of events. And you don't want to find yourself being a prisoner of events. What is the plan for how you're going to communicate this, how you're going to care for the patients in this regard, and how you're going to take care of your physicians as far as what this is going to mean for them? Yeah,
that makes sense. What are some kind of any other final thoughts you guys have or we want people to be aware of? Because I know we've been getting plenty of questions and requests from clients on, first of all, just kind of understanding these the changes in the proposed rule, and then what do we do? How do we even start to digest this stuff? Even though we do have an extra year now, more or less, where do we start taking bites out of this particular elephant?
Yeah, I think just to add on to what Alex just said, the importance of planning ahead, of course, we don't have perfect data on this because no one's been tracking this data, but anecdotally from people we've spoken to and practices we've worked with, there are potentially practices where a single physician could see 1, 2, 3, 4,000 plus work RVUs attributed to an APP in 2 years. And so, that's certainly not going to be every case, but the magnitude of the change that some providers might see could be pretty huge. And so without a plan that's, set up well in advance and, really tries to ensure everyone is as close to happy as possible, is going to be extremely important, or else there's going to be a lot more problems than there otherwise would be.
And Mark, you referenced the article that Chris wrote that's published on our website. It details different key effects that are going to accompany these changes. And so understanding how these different effects impact your specific situation are going to be important. And I think that's what we would advise as far as go for planning, knowing how these different key effects impact what your situation entails.
Yeah, well, that's a good kind of segue or bringing it full circle, because the article does outline a number of key effects, and to Chris's point, as organizations are starting to or continuing to plan for these likely changes, there's going through those key effects that we outline are probably where they could start as far as evaluating, getting ahead of the curve a little bit on understanding exactly how this potentially could impact them or will. And it kind of breaks it down into different areas that they probably need to look at. And whether it's more the operational workflow piece, which there's stuff there that we talked about, or it's the impact on compensation or the behavioral changes. Again, all the stuff we talked about and much more that you guys outlined. So I appreciate you guys taking a few minutes to talk about this and give us a relatively brief rundown on what these changes could look like and how they may impact organizations out there. Again, we'll make sure this article is provided in the notes, and folks can reach out to Alex and Chris to get a little bit better understanding. We have a lot of resources out on our website related to this and the other impacts to the changes in the final rules. So thank you guys. We appreciate it. And I'm sure this won't be the last time we're talking about it. So I encourage folks to stay tuned to more information on this coming out in the near future. We appreciate it.
Thanks for having us.
Thanks.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.